Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echo, vascular, general, high risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Today's guest is Miss Archi Wilfred, the lead sonographer in Premier Care Diagnostics, World Multipurpose Medical Center in Nigeria. She is a dedicated, meticulous, patient-centered diagnostic sonographer with over 7 years of clinical experience. She conducts a first-class quality of diagnostic ultrasound scanning services across a variety of specialties: obstetrics, gynecology, abdomen, small parts, vascular, and 4D scans, providing vital diagnostic information to assist in proper patient care. She has a Bachelor of Science in Radiography and Radiological Sciences. She has a postgraduate diploma in ultrasound and international CPD certifications in fetal anomaly ultrasound, abdominal ultrasound, and abdominal anatomy, gynecology, ultrasound, and ongoing sessions in advanced obstetrics ultrasound course organized by Medicos Prep Academy. She is HCPC registered sonographer. She is skilled and has vast knowledge in carrying out general and specific ultrasound scans of all body parts, including obstetrics and gynecology, abdominal, small parts, vascular, musculoskeletal, 4D, and contrast-aided ultrasound investigations. Please help me welcome Archi Wilfred. Archi comes to us from Nigeria today, and I'm excited to talk with her. She is going to just go over some basics of liver ultrasound and how she practices that in Nigeria. Welcome, Archi.
Thank you, ma'am.
So tell us, maybe we should talk a little bit about how healthcare is a little bit different in Nigeria than it is in the US. Can you talk to us about that first before we dive into the liver ultrasound?
All right. The healthcare in Nigeria, for the hospital where I practice in World Medical Center, almost everything we do here is in line with what is done, the healthcare practice in the UK.
Okay.
Because of the MD here, it's a big hospital that's so standard. So whenever it comes to a patient walking into the facility to have a test done, you have to see a doctor for consultation. That's the first step. You see a doctor for consultation. After the doctor speaks to you, he gets to know your complaints, and then he figures out the types of tests you need to do before you undergo any treatment. So I wouldn't know if that's how it's done in the US, but here you need to see a doctor.
Yes, it's done that way here in the US. You do see a doctor first, and the doctor does the consultation and orders the appropriate test.
Yes, recommend the appropriate test. So you carry on the test. After that, you reach out to the doctor. We send the result to the doctor that consulted you. And then the doctor from there, he hands you over to, if it is a pathologist, if it is something that has to do with the gynecologist, we have different doctors. He can now hand you over to the appropriate doctor to carry on the examination and all that.
And so you do have a registry that you obtained to be an ultrasound tech. Is that correct?
Yes, we do. There is a medical body for that. Mine is it's the Radiographers Board of Nigeria. We
Okay.
call that RBN. RBN. That's the board that's regulating radiographers in Nigeria. So you have to get certified with them before you become a practicing radiographer. And of course, also as a sonographer, you would have gone through some PGD, procedures, a 1 year and 8 months course on PGD, postgraduate diploma for ultrasound. You were certified after the examination from the board.
From the board. So very
The board,
similar
yeah.
to the US. Yes, very similar to the US. That's
Yeah.
interesting. Well, that's nice to know. Nice to have you
Thank
on
you.
the podcast. Thank you for joining us. I really appreciate your willingness to come on and share.
Thank you.
Um, and I appreciate all the work that you do over there because in Nigeria and other countries that I've been in, they're not, there's not as many of you to be able to perform. And so it's hard to get good care to lots of
Mm,
patients. So thank you
yeah,
for doing what you're doing. I appreciate it. So talk to us
thank you.
about the liver. Maybe you want to review a little bit of some basic anatomy and the blood supply to the liver, and we'll go from there.
Okay. For the liver, the liver, it's an organ, is a peritoneal organ that lies at the right upper quadrant. And that's basically the anatomy. But if we want to go to the blood supply of the liver, we are looking at the portal vein and the hepatic arteries. So the portal vein is formed by the confluence of the splenic vein and the superior mesenteric artery. So the portal vein bifurcates, the main portal vein divides into the left and the right portal vein to supply the liver. It takes about 75% of the liver's blood supply. It's the major vessel that supplies the liver. So we also have the hepatic arteries. The hepatic artery is coming all the way from the inferior vena cava. It gives the liver about 25% blood supply. So the portal vein, let's start with the hepatic arteries. The hepatic arteries, like I said, from the inferior vena cava, divide into three, the middle, the left and the right hepatic artery. And then that causes, they help to divide the liver into some segment, both the hepatic vein and the portal vein. So basically the hepatic artery divides the liver into the middle hepatic artery divides the liver into the left and the right lobe with the falciform ligament, around there. Then the left hepatic artery,
Is it
it
an
divides the
artery or a
liver.
vein? Is it an artery or a vein?
Okay, it's artery. I'm talking about hepatic artery.
Okay. Okay.
Okay.
Yeah.
All right. The hepatic artery, it divides the liver into that. The left hepatic artery divides the liver into the medial and the lateral parts. The right hepatic artery divides the liver into the posterior and the anterior parts. All right. So the portal veins divides the liver into the superior and the inferior parts. So the hepatic arteries and the portal vein together divides the liver into 8 different segments. 8 different segments. So we have a segment 1 as the caudate lobe. So we have also segment 2 The division, if you want to mention them, you come in a kind of anti-clockwise way, like clockwise, sorry. The division, it's like this clockwise where you have 2, we have 3, we have 4, and then 4 is the superior and the inferior, and then we have 5, 6, 7, and 8 in the clockwise direction.
Nice. So that's how you start your imaging then by you're scanning each segment, right?
Yes, I'm
And that,
scanning each, and I start scanning with the loops actually. I'm looking at the loop first, the left loop, then the right loop, and then the segment, and then looking at the segment for any pathology.
okay. Awesome. Yeah, it's been a while since I've done abdominal ultrasounds. So this is bringing a getting a lot of the cobwebs out of my head. So you mentioned the falciform ligament being a landmark as well.
Yeah, the land that divides the liver into the left and the right lobe. The hepatic veins come from the inferior vena cava and all that.
Yeah. So what kind of preparation does the patient need to have in order to have a liver ultrasound?
Okay. What I know it's basically, it might be different for some centers, but for my center, for where I am, and I think it's generally accepted that the patient should come fasting for at least 8 hours or Nile per mouth. The patient is not supposed to eat. The patient is supposed to come fasting. That's to enable you see through the structures properly. Because sometimes when they've eaten, the whole abdomen it's full of gas, and it might obscure you from seeing some organs like the pancreas and the splenic vein. The structures within the epigastric would be obscured by the gas. Would be within the epigastric region will be obscured by the gas.
Yeah, so do you scan them sitting up or laying down?
Okay. The patient would have to lie supine in a supine position with their hands just above. I love it that the hands is a bit placed, but relaxed just beside so that I don't get I get to see the kidneys properly when I'm scanning.
Yeah, and I think they're breathing, especially in big barrel-chested men.
Yeah,
Their breathing
yeah,
is really important
yeah,
as well, right?
yeah,
I remember that
yeah,
because
yeah,
some of these men have big barrel-chested, and I'm like, oh, I need that
yeah.
liver to come
I
down.
need,
But
yeah.
yeah.
Well, the breathing is so important. While carrying out the examination, the patient is asked to breathe so that the diaphragm can give way for the liver to be fully visualized.
Awesome. So when
Mm.
you do a liver ultrasound, are you also including the pancreas, the kidney, and the gallbladder?
Yeah, basically, if I'm looking at the liver, I don't want to think that it's only the liver I'm scanning. Yes, I am looking at the liver to check for pathologies, but I should be able to visualize the pancreas. Yes, I should be able to visualize the portal confluence. That's the splenic vein, the superior mesenteric artery, and then I should be able to see them. The aorta, I should see the structures around within. I should also check the spleen.
The
The
spleen.
spleen, yeah, for
A lot of kidney
splenomegaly.
men.
Yeah, yeah.
Okay, so you do almost like a full, complete abdomen.
Yeah, yeah. I should also look at the gallbladder, very important. The gallbladder. That is why the patient has to come fasting because there might be something on the gallbladder, like cholecystitis, there are stones within
Right.
the gallbladder. So I'm looking at.
So when you do your ultrasound, do you have access to looking at the patient's chart prior to them coming to see what lab values may be elevated? Or,
Okay. All right. The way I scan here, what the protocol here in my hospital is that I follow up with the results of the patients from the lab section too. I don't know if that is achievable there in the US. Here, I can, after scanning a patient, I can put a call through to the lab to ask what the result of the liver function test is. I just want to follow up what's happened. After scanning, I want to also know what's going on with
uh,
their
so you
test.
look at those tests after you do the scan.
Yeah, that's the protocol here. I look at them after the scan.
Mm, okay. Interesting. Awesome. So tell us about the equipment that you have. So do you have like GE, Philips,
Okay.
any of
Yes,
that?
GE. I use GE.
You use
GE, yeah.
GE.
Yeah.
GE Voluson 9, 10, or what?
Okay. I've not checked the particular one. The type, what is GE, and it's um I think I saw something 20 there, but I'll check it. I've not really checked it, but it's a new
Okay, so it's
model.
pretty
It's a
updated. Good
new
for you.
model. Yes.
Yeah.
It's a new model.
Awesome. So you scan these in both the transverse and sagittal planes. Is that correct? Or longitudinal planes?
Exactly. Yes, exactly. I usually start with the longitudinal planes. If I want to see, the first thing I want to look at is the left lobe of the liver. I want to see the left lobe of the liver. I want to see the entire inferior margin of the left lobe of the liver. I want to see the aorta very opened. So my probe is in the true search so that the notch is in contact with the Zifford process, with the Zifford process around the epigastric area. So I swing my probe. It's all about manipulation, moving your probe to ensure that you get the aorta to be opened, and then you see the inferior margins of the left lobe. That's how I start. And I take an image of the left lobe showing the inferior margin and the aorta. I take that image and then I acquire different images. I go further also to try to angle my probe a bit, still at that epigastric area. I angle my probe a bit towards the patient's right, just a bit, swing my probe to be able to see the entering of the portal vein. That's when the portal vein is it's entering the liver. I want to see that, and then I want to measure it also to know the diameter so that I'm sure that it is good. And then another thing I do is that I also take an image of the probe being in the mid clavicular line, in the mid clavicular line of the patient, around here, down here. I want to place the probe there and then manipulate. Sometimes I get the gallbladder even from there. I get to see the gallbladder from that plane while I manipulate the probe. I also get to get a good image of the right lobe of the liver. And then I also get a good image of the kidney. Like if I want to do a comparison, I want to see the liver and the kidney, the ecotexture and the echogenicity comparison then I use the mid-axillary line
Mm-hmm.
to measure the liver, the that to measure the liver. I also use the mid clavicular lines to measure the measurement of the liver.
Yes.
So, and I also scan transversely also. Transversely, I'll just position my probe first right from the epigastric. At the epigastric, I would rotate it anti-clockwise, like I'll rotate it to be able, and then I'll manipulate while my probe is under the ribs, parallel to the rib. I want to, swim over the probe to get my the division, the inferior vena, that's to get the bifurcation of the middle, left and right hepatic veins.
Yeah.
That bifurcation, yeah. So I want to get that picture properly. And then I take over 7 images. I take 7 images of these different views of the liver. And also there's this, I didn't mention the caudate lobe, very important. I take an image of the caudate lobe. I place my probe just at the epigastric region. I slide a bit towards the patient's right, the face here, and then I manipulate my probe there with a good breath in. I tell them to breathe in deeply, and then I'm able to see the caudate lobe of the liver. And then I'm also able, there's a feature there. I'm also able to see the IVC, the inferior vena cava posterior to the caudate lobe, and the ligamentum venosum anterior to the caudate lobe. The reason I look for that caudate lobe is because sometimes a hypertrophy of that caudate lobe can give you a sign of liver cirrhosis. So
Yeah, you talk about different things that you see in the liver and the different patterns of things that we can see in the liver with the echogenicity of the liver. And you talk about how the liver can be bright with fat deposition,
yeah.
or cirrhosis or obesity, but you also talk about that can occur with disturbed metabolism like diabetes or even starvation is what you mentioned in your PowerPoint. How often do you see that in your country, starvation?
Oh, I see that often. I see that often. My country is a special one. We're in Nigeria. I know our hospital is quite big, but most times we have patients coming in that you would know from even their history, you would know that this whatever you're seeing is it's linked to starvation because you're conversating with the patient and you're getting information from the patient and you know that this patient has been through a lot. So you know that this is not actually whatever you're seeing may not be actually linked to a kind of pathology like that fatty liver infiltration. Fatty liver infiltration, it comes with some um I don't know how there's something I want to explain. Fatty liver infiltration, it should be more amongst people with very huge body habitus, people with so high cholesterol level, you know, but you will see a patient walking and the patient is not really that big. It's not, the patient has quite a good body habitus.
Yeah.
And yeah, but you're still seeing the liver this way. You know that it's linked to something.
Interesting. In the US, we don't see starvation very often, right? We
Mhm.
have much obesity, um,
Mhm.
but not starvation. So I think that's an interesting difference between your country and our country. And I'm sorry that you have to witness that. That's super sad to me. You know,
Yeah.
living in the US with having so much available to us that other people in the world don't have that, right? That seems
Yeah.
like a basic human need that needs to be met. So, um, I'm sorry to hear about that. But you
Yeah.
also talk about the cirrhotic liver and how
Okay.
um, it looks really coarse and kind of bumpy and different
Mm-hmm.
things. Um, and how the spleen appears when you have cirrhosis. Can you talk more about that?
Okay. The spleen will be very enlarged splenomegaly, and then it will be very thickened and accentuated in equal texture or very enlarged splenomegaly.
Yeah, and it looks pretty it can look rather for lack of a medical term lumpy, right?
Lumpy, yeah, yeah,
Yeah, and
lumpy,
maybe some fluid around it at times.
yeah. Then ascites.
Ascites, that's right.
Mm.
So what are some other things that you see in that country? You have here that you've seen hepatic cyst and hydatid
Yes,
cyst. Um,
yes.
talk about that.
Okay, okay. Hepatic hydatitis, they are multi-septated kind of cysts, fluid-filled cyst. You can also see some daughter cyst inside the cyst itself. So, and it's common here in Nigeria because of the cause. Because of the cause, it's majorly linked to bacteria or fungi, all those infections. So it's common here in Nigeria. It's common because of the particular bacteria that causes Escherichia this thing.
Yes. Yeah. And those cysts can be calcified as well. Is that
Yeah,
correct?
yes, we have a calcified hydatitis cyst that it has calcified walls, and you will see some posterior shadows from the calcification on scan.
And how common are hemangiomas? I mean, here in the US, we see them pretty often. Do you feel they're pretty common for you guys as well?
No, it's not really common. It's not that common, but I do see it. Like last month, I saw one. I saw one on a young adult, not too old, and it was an incidental. It was an incidental finding. She doesn't even know she had that, but as I scanned, I saw it there, echogenic, hyperechoic, and round on the liver, round shape on the liver.
Yeah. And some other um pathology that you see are focal nodule hyperplasia.
Okay, yeah, I've seen that twice. I've seen that twice. One was here in this hospital. Why one was when I was with a public hospital, a general hospital. I've seen that there. And I saw one here recently, focal nodular hyperplasia. So basically it was of course ovoid shape, and then it has a hypoechoic, sometimes it could have some mysticogenicity, but the main thing is the the Doppler. On Doppler, when you use a Doppler of this thing, you see the flow round the mass, like a spoke wheel appearance kind of flow, Doppler flow when it round the mass.
Yeah, they can kind of sometimes be a little subtle and hard to
So
pick
that,
up,
yeah.
right? Because you might see their borders there and then you don't, and then you put the color flow on and you're like, oh, well, there it is, right? You,
Yeah.
or sometimes they can be a little bit more hyperechoic even.
Hyperacute, yeah,
Yeah.
yeah.
And really kind of stand out a little bit more. Tell us about hepatic adenomas.
Okay, all right.
Hepatic
I do,
adenomas.
all right. Hepatic adenomas are just benign, they are benign liver masses. They're not cancerous, they're just benign, but they could the the echogenicity, they could be heterogeneous. They could be heterogeneous. They can have mixed echogenicity. They could be hypoechoic. It depends. But what differentiates hepatic adenomas from um, it's just the Doppler. When you use Doppler, adenomas, they are benign. So because they are benign, that vascularity won't be as much. And
Right.
even if it could be at the periphery, not in the lesion, just at the periphery of the walls of the lesion. So that's what we use to differentiate, basically.
Yeah, and these can cause some abdominal pains, but they're
Yeah.
caused from the use of some oral contraceptives or
Correct. Contraceptive, yeah. The
anabolic,
steroids.
sorry, steroids. Yeah. Yeah, and
That is
then
correct.
hepatocellular carcinoma.
Those are the main or primary liver, primary liver cancer, malignant lesions, tumors on the liver. The reason they are called primary is because they are arising from the liver itself. The hepatocyte, the cells of the liver get dysfunction and then they arise from there. Or it can be infiltrated from other organs to the liver. That's secondary metastasis. Yeah.
Yeah, is it hard to tell the difference between HCC, hepatocellular carcinoma, and metastasis?
Yeah, it's not hard. I feel that the patient history would direct you to know if this is hepatocellular carcinoma, and if this is met. Hepatocellular carcinoma, the patient must have had some this thing, some other hepatitis, I think C. Yeah, the patient history
Yeah.
is would be the difference. While secondary liver metastasis, it could be arising from the colon, like colon cancer infiltrating into the liver.
Or
So the
pancreas.
history is primarily how you differentiate them,
Yeah.
the indication.
And you talk about the fatty liver and using the kidney as your comparison.
Yeah, yeah, yeah. So the fatty liver, I see that a whole lot. It's so common here in Nigeria. I get to see it often. So there's a rating of fatty liver at the stages, stage 1, stage 2, and stage 3. And we're looking at different things. In stage 1, the echogenicity of the liver is just a bit more increased than that of the kidney. And then the hepatic and intrahepatic vessels are preserved. The echogenicity, the walls of the portal veins are still intact. And then in stage 2 of fatty liver infiltration, you will see that the echogenicity of the liver is moderately increased, not mildly, moderately increased. And then there will be loss of portal vein walls, and the intrahepatic vessels might be concealed. But you see the diaphragm, you see the echogenic outline of the diaphragm. But in grade 3, you would have to look, you might not see any, you wouldn't see the echogenicity of the diaphragm. The echogenic diaphragm would not be visible, or it will be ill-defined. You can also see that there's loss of portal vein wall, and of course the intrahepatic this thing, vessels will not be clearly delineated. So that's stage 3. And then stage 3, you might also see hepatomegaly, like the liver might be increased in size as well.
Hmm. And why do you think that you see that a lot there in Nigeria? What do you think the cause of that is?
It's majorly our feeding, the way we feed here, what we eat, our food, our meals, our diet. They are more of a carbohydrate fatty, everything fatty and more of carbohydrate meals. That I think that's linked to it. And Nigerians, most Nigerians love to take alcohol to, you know,
Yes.
I
Yes.
think that could be a major cause too.
So you talk about focal fatty infiltration as well.
Yeah, that's just so a focal area in the liver, in the normal liver parenchyma that is a bit more hyperechoic than the other surrounding parenchyma. You just know that there's a focal stuff here. Yeah, that's hyperechoic, but there's focal fatty infiltration, which is more like it's hypo as compared to the liver parenchyma.
Yeah. Yeah. No
Mhm.
shadowing, right?
Yeah, no shadowing. Yeah.
And then you have focal fatty sparing.
Yeah, that's just a part of the liver. Still, in a normal liver parenchyma, you're seeing some focal parts that seem to be a little more with reduced echogenicity.
Yeah.
Mm.
And cirrhosis. We talked about this mean
Mm.
disease already. Um,
Mhm.
viral hepatitis. Do you see this often?
Yeah, I see it. I see it. I see it. It's often, and hepatitis is kind of predominant, I think, in Nigeria. It's kind of so of course once I see that sign, the starry sky sign, I would start to question you as a patient to get your history. And most times they get to tell me that they tested. Once I see it, I'll ask if you have hepatitis B or if you have any history of such. And most times they say yes, that they do. So you just see some echogenic, that's the portal, this thing will be so prominent, the walls will be so prominent, giving a kind of scary sky appearance.
Starry sky, yes.
Yeah,
Yeah.
yeah,
With thick walls. Yeah.
the thick
And
walls,
just
yeah.
because of viral infections over there, correct?
Yeah,
Yeah.
yeah.
So then talk to us about portal hypertension and how you identify that and how it's treated over there.
Okay.
Or
So for
what
portal,
happens that you would suspect that?
so most times I portal hypertension occurs most times in when a patient presents with liver cirrhosis, and some of them are congestive cardiac failure and so on. So basically, the portal vein gets enlarged. It gets so enlarged. That's how it presents. So you're measuring it and it's above the normal value. Um, um, Before the normal value, let me say I've read from two to three different textbooks. One said the normal value it's around 13 mm, 15 mm. Some persons say it's 15 mm, that's 15 mm. So, but once it is just above, once you're having like 17 mm, 18, 20, 20 something, it means that there is really enlargement on the portal vein. And how do you see that? On Doppler imaging, when you use Doppler, the portal vein is very enlarged, and you see that the hepatic vein is enlarged also. You see other collateral, other vessels. Once the portal vein is having that pressure, the blood flow is decreased.
Mhm.
So other vessels like the hepatic ear vessels begin to stand in to help to circulate blood through the liver as collateral this thing. So what you see on color Doppler is turbulence, a kind of turbulence flow where you see mixture of the red and
Mhm.
this colors on Doppler imaging. So on Doppler imaging also for the portal vein, it's monophasic. It has a monophasic flow, continuous flow. It's not supposed to be biphasic. The normal flow is just forward flow and then smooth flow and then monophasic. But in cases of portal hypertension, you will notice that there is biphasic flow. There is flow above and below the baseline in Doppler imaging. So you just know that there's something wrong somewhere. You start thinking, could it be congestive cardiac failure? And then if there is a liver cirrhosis, of course, that it's the cause. But when you check, you notice that also there's something I observed some time ago when I was doing a Doppler of the in a portal hypertension patient. The splenic vein was also enlarged.
Ah,
The splenic vein was also enlarged. I noticed that. And most of the blood, it's as though it was gorging to the splenic vein. So I had to browse it. I had to browse it, and I noticed it was called splenic steel syndrome or some, yeah.
ah,
So
nice. Yeah. So color flow is really helpful in these areas because you can get hepatic or portal hypertension from cirrhosis or any other disease that's going on in the liver as well, right? Or an
yeah,
obstruction of some kind, correct?
yeah, thrombosis, yeah.
So you don't want to have reversal or biphasic flow at all in that portal vein, right?
Um, yes, I don't want to have a reversal because it's supposed to be a monophasic flow, but there's in a patient who is a young adult male who gyms, who does exercises, who gyms after exercise, you can get that flow, but you should be sure that the is someone who is always gymming, who is always into athletics.
Yes.
Otherwise, it's linked to other pathologies.
Yeah. So once again, here, in ultrasound, the patient's history, and we're kind of like detectives, we're trying to go and look for things that may cause their symptoms. And so, um, being able to think like a physician. Do you have radiologists then who read your scans there in Nigeria?
Okay. Yes, I have the HOD of the unit of the radiology department. He's also a sonologist. So I am directly under him. I'm the lead of the team, but he's the HOD of the department. So there are times, yes, he reads what I give out, he reads it, and then if there's any improvement, if there's anything he wants me to add up to what I've done, I add up, of course. But most times it's like now he's on leave. It's not every time he's around.
Okay. Yeah.
Yeah, right now he's on leave, so I'm all alone. And that's the reason why I take courses a whole lot. I take courses a whole lot that will advance my skill, and I do courses a whole lot, and I study a whole lot so that I'll be able to give out the best results I can for
Awesome.
to help in diagnosis here.
Yeah, that's amazing. So, how many scans do you do in a day?
All right. We book, like I said, here it's just like a practice outside Nigeria, because of the hospital. We book scans, and then we leave places for emergencies. So we book up to from 15 to 20 in a day, from
Okay.
15 to 20 in a day, and then but we leave room for emergencies. That's why we book up 15 to 20 in a day. So
15
we
to
can,
20 in a day. And how many ultrasound techs do you have?
okay. I have, I basically do it. If it's not around, I do everything. I do everything.
So, you don't have like two or three ultrasound techs. You're the only ultrasound tech and you do 15 or 20 a day.
Yes.
Wow. Do you have to fill out a report after each one of these scans?
Yes, I do.
You do. Wow.
Yeah. Um,
So are they scheduled every 30 minutes?
Yeah, I use just 10-15 minutes to do the scan.
Ah, okay.
Yeah, I use 10 to 15 minutes to do the scan, except it's something I have to take my time to. Yeah, we can extend it. If it's something I have to look at very well, we can extend it. But every patient, it's at least 30 minutes per patient.
Yeah.
And
Yeah.
I work long hours. I work longer hours too.
How
I
many
work for
hours in
long.
a day do you work?
Right now, I resume by 9 a.m. and I close by, they are long. I close by 8 p.m.
Ah,
Yeah,
yeah, that's a long day. Yeah.
it's a long day. It's, I walk in and like, it could be 4 days in stretch, 4 days in stretch,
Uh-huh.
those hours, yeah.
Yeah.
And then 2 days off and then back just like that.
Ah, okay. Awesome. Well, that's amazing. Well, I
Thank
have a
you.
special place in my heart for Nigeria. When I was growing up, my mom and dad befriended a couple who came from Nigeria and
Um,
to the United States. And so my dad taught this man how to drive because my dad taught driver's ed. And then my mom taught the woman how to cut up a chicken and fry the chicken. And they
oh,
taught us how to make ching ching.
wow.
Are you familiar with ching ching?
Yes, yes, ma'am, I am. Mm.
So, um, their son's name was Denabasi, and we played with him. He was our age, and we played with him like any other child. And it's just a very, very sweet memory that I have. Um, John and Asinowin were their names, and John would go back home to Nigeria to visit some family, and he would bring me, I still have a child's necklace that he bought me from Nigeria that I just treasure. So,
Oh,
um, it's just very sweet memories for me. Um,
thank you.
of spending time with them, and they would teach us their songs and teach us their dances, and it's just a sweet, sweet memory for me as a child. So I have a special place in my heart for Nigeria, and one of these days I'll visit, but
Wow, I
haven't
would
been
love to
able.
have you.
But I haven't made it over there yet. So I will look you up or call you when I decide to come or when I'm able to come. So
Thank you, ma'am. Thank you so much, ma'am.
yeah, we, your people are very precious and sweet and full of faith and joy. And
Thank
so
you.
thank you for the work that you do. Those are long hours. That's a lot of patience. So I'm happy to know they're getting good care at some place because they have to travel far to get there. Is that correct?
Yeah, yeah, exactly.
Yeah. What does your husband do there?
Oh, all right. I am not married at the moment.
Oh,
I'm a
okay.
single lady. Yeah, I'm a single lady.
Awesome.
But I'm hoping on marriage soon. I'm praying about it, and I
Awesome. I'm
believe.
sure. I'm sure you
Yes,
will.
ma'am.
You're very smart. I saw a young man helping you, I think, with technology. So I thought maybe that was your,
Yeah.
but maybe not.
No. Oh, it's my colleague here.
Oh, your
It's my
colleague. Oh,
colleague.
I am so sorry.
Yeah. Hi.
Hi, hi. Thank you for your help. Nice to meet you.
Mhm.
Well, thank you so much for sharing with us about the basics of ultrasound for the liver and the different diseases of the liver. And thank you for the work that you do all the way across the world. I am so honored that you chose to come on and share your experience and what it's like over there and the different kinds of things that you see over there versus what we see here in the States. So um, I just appreciate your experience and your sharing. Thank you so much.
Thank you.
Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend and remember to keep your frequency high.